Um, Imagine a burglar who doesn't just like break into your house, but physically dismantles your kitchen to build exact copies of himself.
Right, using your own appliances to do it.
Exactly. And worse, he leaves you with absolutely no tools to stop him because, well, he's using your own pots and pans. That is the fundamental nightmare of treating viruses.
It really is.
Today, we are looking at a massive stack of medical pharmacology notes and clinical research on non-HIV antiviral drugs. And our mission for this deep dive is to figure out how we kill that burglar without burning down the house in the process.
Yeah, it is the ultimate biochemical balancing act. I mean, if you are a first-year medical student staring down a pharmacology exam or just a deeply curious learner listening right now, this topic can feel like a chaotic list of unpronounceable names.
Completely. It's alphabet soup.
Right. But the context you need to ground yourself is that viruses are obligate intracellular parasites. They don't have their own biological factories.
So they literally hijack our host cellular machinery to replicate.
Exactly. They hijack it. So designing a drug that is toxic to the virus, but, safe for the host cell,
Yeah.
is incredibly difficult.
Okay, let's unpack this, because the traditional way to learn this is pure brute force memorization. Just flashcards on flashcards.
Which is miserable.
It's terrible, but our sources make a very compelling case. If you understand the actual molecular logic, like the mechanisms of drug action, that chaos turns into deduction.
Yes, you don't have to memorize a list if you understand the biological rules. That shift from memorizing what a drug does to understanding how it does it is everything.
Well, so we're going to build this logically. Let's start with a virus that replicates quickly and bursts out of cells to spread. Influenza.
A seasonal heavyweight.
Right. To understand how to stop the flu, you really have to look at how the flu leaves an infected cell to infect the next neighborhood. And that brings us to the most famous flu drugs, the neuraminidase inhibitors.
Yeah, for influenza A and B, we have a specific class of drugs that target viral packaging and release. The primary player in the research is oseltamivir.
That's the oral capsule, right?
Right, an oral capsule or suspension. And we also see zanamivir, which is an inhalable alternative.
Okay.
The mechanism here relies on inhibiting neuraminidase. Think of neuraminidase as a specific enzyme on the surface of the influenza virus.
So by blocking this enzyme, these drugs stop the release of the new progeny virus from the infected host cells.
Exactly. The virus replicates, but it can't escape to cause new rounds of infection.
I always picture this like a car manufacturing plant. Like if the virus is a newly assembled car inside the factory, neuraminidase is essentially the key that unlocks the factory gate so the car can drive out.
That's a great way to look at it.
And oseltamivir comes in and permanently changes the locks on that gate.
Yeah, the visual of those viral cars just piling up inside the cell, completely trapped, is highly accurate. Oseltamivir has the most extensively established efficacy and safety record, making it the drug of first choice for treating the flu.
But the mechanism dictates the clinical window, doesn't it?
It does. Because it only stops the release of new viruses, you have to administer it early, ideally within 48 hours of symptom onset.
Because if you wait too long, the virus has already flooded the neighborhood.
Exactly. The damage is done.
Okay, and what about the inhalable one, zanamivir? I imagine breathing a drug directly into the lungs comes with its own specific rules.
Oh, absolutely. The pharmacology dictates extreme caution with zanamivir. Because it's inhaled directly into the respiratory tract, you generally avoid it in patients with underlying airway disease.
Like asthma or COPD.
Right. The localized irritation can easily trigger a severe bronchospasm.
Yikes. Okay, but if oseltamivir is so effective, why do our clinical notes even list a backup plan? Does the flu virus just, figure out how to pick the new lock on the factory gate?
Well, the evolutionary arms race between drugs and viruses basically guarantees it. We frequently encounter oseltamivir-resistant strains.
Where the virus has simply mutated its neuraminidase enzyme.
Right, so the drug can't bind to it anymore. And when that happens, we have to attack a completely different part of the viral life cycle. This is where we introduce a drug called baloxavir.
Baloxavir, and I'm looking at the notes here. This is not a neuraminidase inhibitor at all.
No, it's not. Baloxavir is an endonuclease inhibitor. Instead of stopping the virus from leaving the cell at the end of its life cycle, it stops the process much earlier.
Okay.
It specifically targets the viral polymerase acidic protein, inhibiting a process known as cap-dependent endonuclease.
Wait, let's break down cap-dependent endonucleases for a second.
Yeah.
What does that actually mean for the virus?
Think of it as blueprint theft. To make its own proteins, the virus needs to trick the host cell into reading viral messenger RNA.
Right.
To do that, the virus essentially snatches a chemical cap from the host's own RNA and attaches it to its own viral RNA, making it look legitimate.
Oh, wow. It literally steals our cellular IDs.
Exactly. And baloxavir blocks the enzyme responsible for that cap snatching. If the virus can't initiate viral mRNA synthesis, it can't manufacture any proteins.
That is incredible. So oseltamivir hits the virus at the shipping stage, but baloxavir hits it at the blueprint stage.
Right.
The factory never even gets built.
Yeah, and the pharmacokinetic profile of baloxavir is striking. It has a massive 96-hour half-life.
Wow, 96 hours.
Yeah, it stays active in the system for so long that a patient only requires a single oral dose to treat the flu,
Hmm.
which is a massive win for clinical compliance.
I mean, obviously.
Yeah.
But there is a huge clinical warning attached to that single dose that you absolutely have to know as a future provider.
Yes, there is.
The pharmacology notes are screaming in bold letters here. Never let a patient take baloxavir with dairy products, antacids, or calcium supplements.
Yeah, the culprit there is polyvalent cations.
So like elements like calcium, iron, magnesium, or zinc.
Right. They carry positive charges that chemically bind to the drug molecule in the digestive tract. This forms a heavy, insoluble complex that the body just can't absorb.
Oh, I see.
So if a patient washes down their single dose of baloxavir with a glass of milk or, a calcium-based antacid, the drug just passes right through their system, completely useless.
It's those exact details
Yeah.
that separate rote memorization from actual clinical practice. You really have to know the chemistry.
You do.
So we've seen how to attack a virus that replicates quickly and bursts out of cells. But what if the virus doesn't do that?
The sneaky ones.
Yeah, exactly. What if it retreats into our nervous system and hides out for decades, only to reactivate later? Let's look at the herpes viruses.
Specifically HSV1, HSV2, and VZV, which causes chickenpox and shingles.
Right. How on earth do you target a virus that establishes latency like that?
Well, you trick it into weaponizing the drug against itself. For these viruses, we use a class of drugs called guanosine analogs. The gold standards here are acyclovir and its prodrug, valacyclovir.
I was reading the notes on acyclovir, and here's where it gets really interesting to me. The drug is basically useless on its own, right? It's administered as an inactive prodrug.
Completely inactive. If acyclovir enters a healthy, uninfected human cell, nothing happens at all. It just floats around harmlessly.
Right.
But when it encounters a cell infected with a herpes virus, it meets a specific viral enzyme called viral thymidine kinase.
And the virus uses this enzyme to prepare building blocks for its DNA, right?
Exactly. The viral enzyme looks at the acyclovir, mistakes it for a normal building block, and adds a phosphate group to it.
So the virus takes this harmless-looking molecule and accidentally arms it.
It does. That's the first step of the arming process, yes.
Wow.
Once that initial phosphate is attached specifically by the viral enzyme, our own host cellular kinases jump in and add 2 more phosphate groups.
No.
Now you have a cyclovir triphosphate to the viral DNA polymerase, the machine that copies the virus's genetic code. This armed molecule looks almost identical to guanosine, the normal building block it desperately needs.
But it's a trap.
A total trap.
A lot of older textbooks call this a Trojan horse, but reading the actual mechanism, it sounds more like slipping a defective brick into a builder's supply pile.
I like that analogy better, actually.
Right. The virus's own enzyme blindly picks up the brick and cements it into the wall of its growing DNA chain. But this specific brick is completely smooth on top.
That smooth top is the key. Chemically, acyclovir lacks a crucial 3' hydroxyl group.
And in the world of DNA synthesis, that hydroxyl group is like the chemical hook that allows the next building block to attach.
Right, so when the viral polymerase inserts the acyclovir brick, there is no hook for the next piece of DNA. The builder can't stack another brick on it, and construction permanently halts. We call this irreversible chain termination.
And it is completely irreversible because the proofreading enzymes, the exonucleases that normally fix mistakes, cannot pry that defective brick out once it's locked in.
No, they can't. It's a brilliant, highly selective mechanism.
But if acyclovir is so clever, why does the outline emphasize valacyclovir so heavily?
Well, the limitation of acyclovir is its oral bioavailability. Only about 15 to 30% of an oral dose actually survives the digestive tract to make it into the bloodstream.
Oh, that's really low.
It is. Valacyclovir was engineered to solve this. It is an alveoline ester prodrug.
Okay, let's translate alvyl ester prodrug for the curious learner. What does attaching that ester actually do?
Think of the valine ester as a VIP boarding pass for the intestines. our gut has specific active transport channels designed to absorb amino acids like valine from our food.
Okay.
By attaching valine to the acyclovir molecule, the drug hijacks those transport channels and gets actively pulled across the intestinal wall.
Oh, wow. So it sneaks in through the VIP line.
Exactly. This gives valacyclovir 3 to 5 times the oral bioavailability of acyclovir.
That's a huge difference.
It is. Once it's in the blood, liver enzymes immediately cleave off the VIP pass, leaving you with high, sustained levels of active acyclovir. It simply means the patient can take pills much less frequently.
That is such an elegant workaround. And just to cover the topical applications in our sources, there's a specific medication mentioned for severe HSV infections of the eye, like epithelial keratitis.
Yes, we use trifluridine for those specific ophthalmic cases. Mechanistically, it's similar, but instead of being a guanosine analog, trifluridine is a thymidine analog.
And it's categorized specifically for topical use.
Right, because it's highly effective at penetrating the cornea to treat those dangerous localized viral infections without causing systemic toxicity.
Okay, so this entire defective brick strategy relies completely on the virus having that specific enzyme viral thymidine kinase to mistakenly pick up the drug and activate it.
Correct.
So what happens if we encounter a virus in the herpes family that just doesn't have that enzyme?
Cytomegalovirus, or CMV, is the perfect example of this. CMV is a herpes virus, but it does not encode for thymidine kinase.
So the acyclovir just sits there.
Yeah, because acyclovir strictly relies on that specific enzyme for activation, it is practically useless against CMV. To fight it, we have to look at what enzyme CMV actually uses.
Okay.
It turns out CMV uses a different kinase called UL97.
So we just need a different defective brick that the UL97 kinase will recognize.
And that brick is ganciclovir, or its oral prodrug, valganciclovir. The UL97 kinase performs that crucial first phosphorylation step on ganciclovir.
Oh, I see.
But the superiority of ganciclovir for CMV isn't just about activation, it's about endurance. The intracellular half-life of activated ganciclovir is around 12 hours.
Wait, 12 hours. The acyclovir only lasts, what, 1 to 2 hours inside the cell?
Exactly. That prolonged presence makes ganciclovir a powerhouse at suppressing CMV replication.
This all makes logical sense, but it raises an obvious question. If our entire strategy relies on the virus having these specific kinases, thymidine kinase for HSV, UL97 for CMV, what happens when the virus mutates and simply stops producing the kinase?
Well, then the drug remains an inactive prodrug. It just floats harmlessly while the virus replicates out of control.
Ooh.
That is the exact mechanism behind acyclovir-resistant HSV and ganciclovir-resistant CMV. The virus simply drops the enzyme we rely on.
So what do we do then?
When the virus outsmarts the activation step, we have to bypass activation entirely. We pull out the heavy-duty backup, which is foscarnet.
Foscarnet. The notes describe this as a pyrophosphate analog.
Right. The mechanism of foscarnet is basically brute force. It does not need to be phosphorylated by a viral kinase. It is already active.
Okay, so it just skips the middleman.
Exactly.
All
It
right.
binds directly to the pyrophosphate binding site on the viral DNA polymerase itself. It acts as a non-competitive inhibitor, essentially jamming the gears of the polymerase so it can't cleave pyrophosphate from the growing DNA chain.
And viral replication stops immediately.
Just shuts down.
But if it bypasses the whole activation step and goes straight for the polymerase, why isn't foscarnet our first choice to begin with? I mean, it sounds foolproof.
Well, the clinical trade-offs are severe. Because foscarnet doesn't require specific viral activation, it is much less selective, which means higher toxicity for the host. Specifically, it is highly nephrotoxic. It can cause massive damage to the kidneys.
The sources also highlight severe electrolyte imbalances with foscarnet. Why does it cause the patient's electrolytes to crash?
Well, because foscarnet is a pyrophosphate analog, its chemical structure mimics a mineral. In the bloodstream, it acts like a chemical sponge.
A sponge?
Yeah, binding up or chelating the free calcium and magnesium in the patient's blood. This crashes their electrolyte levels, which can lead to seizures or arrhythmias.
Wow.
Add in the fact that it has poor oral bioavailability and must be given through an IV, and you can see why it's strictly a heavy-duty backup for resistant strains.
Right. Mechanism dictates the side effects. It all connects perfectly.
It always does.
All right, we've gone from the fast burst of the flu to the latent hiding of the herpes viruses. Let's shift our focus to viruses that smolder quietly in our organs for decades, constantly shedding and damaging tissue.
So liver viruses.
Yes, specifically hepatitis B and hepatitis C. Here, the sources present a totally different strategic choice. Do we attack the virus directly, Or do we supercharge the host's own immune system to clear the infection?
The immune superchargers are fascinating. For both hepatitis B and C, the sources highlight interferon alpha 2b.
Now, this isn't an analog that targets a viral polymerase, right?
No, interferon is a recombinant cytokine.
Let's define cytokine for the listener. That's essentially a chemical distress signal that our immune cells use to communicate, right?
When a cell is under viral attack, it naturally releases interferons to warn neighboring cells. Interferon alpha 2b is a synthesized version of that distress signal.
Oh, interesting.
When administered to a patient, it binds to host cell receptors and sets off a massive systemic alarm bell. It triggers a cascade of cellular defenses that inhibits viral penetration, translation, transcription, and assembly, while simultaneously ramping up the host's immune cells to hunt down the virus.
But reading the clinical reality of setting off that alarm bell, the cost to the patient is massive.
It's very costly.
Treating someone with interferons is notoriously brutal because you're deliberately inducing severe systemic flu-like symptoms. And beyond the physical fever and chills, the notes say it frequently causes severe clinical depression.
Yeah, the psychiatric side effects are a major limiting factor. It's an incredibly harsh therapy, which is why modern pharmacology has aggressively pursued direct-acting antivirals to replace it.
Makes total sense.
Before we dive into the specific direct actors for hepatitis B, I should quickly mention ribavirin.
Okay, what's that one?
It's a riboside analog with multiple mechanisms of action, often used as a combination therapy for hepatitis C, and sometimes for severe respiratory syncytial virus, or RSV, in highly specific patient populations.
Okay, good to know. But let's focus on the direct-acting drugs for chronic hepatitis B. The stars here are adefovir and entecavir. The notes classify them as nucleoside and nucleotide analogs.
Yes, hepatitis B is a very unusual DNA virus. During its replication cycle, it relies on an enzyme called reverse transcriptase to convert RNA back into DNA.
Which is a process very similar to how HIV replicates, right?
Exactly. Entecavir and entecavir directly target and inhibit this HBV reverse transcriptase.
The sources specifically label entecavir as a first-line oral therapy because it has a high barrier to viral resistance. I want to push on that. Why does it have a high barrier? Why can't the virus just mutate its reverse transcriptase to reject the drug, like we saw with the herpes kinases?
That's the beauty of it. The consequence of entecavir's chemical structure is that it fits the active site of the viral reverse transcriptase so perfectly that any mutation the virus makes to reject the drug also destroys the enzyme's ability to function normally.
Oh, wow.
The virus is trapped. If it mutates to escape entecavir, it loses its ability to replicate its own DNA. It's a biological checkmate.
That is brilliant. Okay, so here is the biggest clinical pearl in this entire section. So what does this mean for you, the provider listening right now? The pharmacology notes mandate that you absolutely must test your patient for HIV before you ever start them on entecavir or adefovir for hepatitis B. Why?
This is a critical point of patient safety. Because entecavir and adefovir inhibit reverse transcriptase, they don't just work on hepatitis B, they also have mild activity against HIV's reverse transcriptase.
Right. If a patient has an undiagnosed HIV infection and you give them entecavir monotherapy for their hepatitis B, you are inadvertently treating their HIV with a single weak drug.
And because HIV replicates with such a massive viral load and makes so many genetic errors, exposing it to a single drug just guarantees resistance.
Exactly. The HIV will rapidly mutate around the entecavir, developing antiretroviral drug resistance that could permanently compromise the patient's future HIV treatment options.
So you always rule out HIV before treating hepatitis B.
Always.
That is the kind of insight that saves lives in the clinic. Okay, we've covered locking the release gates, throwing defective bricks into DNA, and supercharging the immune system. Let's conclude our analysis with pandemic heavyweights.
The drugs developed for SARS-CoV-2.
Yes, the research here exploded out of necessity, yielding two therapies with completely different mechanisms. First up is remdesivir.
Remdesivir is a nucleotide analog. What's interesting is that it wasn't designed from scratch for COVID-19. It was originally developed and tested during outbreaks of other viruses, like Ebola. Oh, I remember that.
Yeah, but it proved highly effective against SARS-CoV-2. It specifically targets and inhibits the RNA-dependent RNA polymerase of the virus.
So by jamming this polymerase, it effectively halts the virus's ability to copy its RNA genome.
Exactly. Clinically, it's administered intravenously and has been vital in shortening hospital recovery times for severe patients.
Contrast that intravenous approach with the oral option that made global headlines. Nirmatrelvir, which is packaged with ritonavir.
Nirmatrelvir abandons the polymerase strategy entirely. It is a specific inhibitor of the main protease, or MPRO, of SARS-CoV-2.
Yeah, and a protease is basically a pair of molecular scissors, right?
That's a perfect analogy. When SARS-CoV-2 replicates, it translates its genetic code into massive, long polyproteins.
Yeah.
These long proteins are basically useless until they are chopped into smaller, functional pieces.
Good.
The main protease is the scissors that do the chopping. Nirmatrelvir binds to the scissors and stops them from working.
So without those functional pieces, the virus cannot assemble itself.
Right. And because the structure of those scissors is highly conserved, meaning it rarely changes across different viral variants, nirmatrelvir offers excellent broad-spectrum activity against mutating strains of COVID-19.
That makes a lot of sense. But what about the second drug in that package? What is ritonavir actually doing? Because it doesn't kill the virus, right? The notes call it a pharmacokinetic booster.
Ritonavir acts as a chemical bodyguard. Our liver has a natural detoxification system, primarily driven by a family of enzymes called CYP450.
Right, the liver's cleanup crew.
Exactly. These liver enzymes are incredibly efficient at identifying foreign drugs like nirmatrelvir and breaking them down before they can even do their job. Ritonavir is a potent inhibitor of those specific CYP450 liver enzymes.
So the ritonavir basically distracts the liver's detox system, so the nirmatrelvir can slip past and stay active in the bloodstream much longer.
Precisely. By inhibiting the liver's breakdown process, ritonavir boosts the plasma concentration of nirmatrelvir to levels high enough to effectively stop the virus. Again, understanding the mechanism tells you exactly why the two drugs must be packaged together.
It is incredible to step back and look at the full picture we just painted. The deeper insight here isn't just a list of side effects. It's that antiviral pharmacology is essentially a game of high-stakes molecular chess.
It really is.
Every time we target a specific viral enzyme, whether it's the factory gates with oseltamivir or the defective bricks of acyclovir or shutting down the molecular scissors of SARS-CoV-2, we apply immense evolutionary pressure that forces the virus to adapt, mutate, or die.
And that brings us back to the fundamental mission of this deep dive. Memorizing these drugs as a flat list is an exercise in frustration. But when you understand the mechanisms, knowing exactly what enzyme the drug targets, how it requires activation, or how it acts as a pharmacokinetic booster, you can logically predict which drug to use. You can predict why phosgarnet crashes electrolytes, why a drug might fail, and exactly what to do when viral resistance inevitably occurs. Mechanism replaces rote memorization with critical clinical thinking.
Which takes us right back to our burglar metaphor. We don't just have a list of random weapons. We have a systematic understanding of exactly how the burglar operates, step by step.
Exactly.
And I want to leave you with this final provocative thought to mull over. We spent so much time and billions of dollars in research designing brilliant analogs to target specific viral enzymes, the kinases, the polymerases, the proteases. But as we've seen, viruses replicate incredibly fast, and they mutate constantly, creating endless moving targets. What if the future of antiviral pharmacology isn't about chasing viral mutations with new analogs? What if the next great breakthrough is about finding a way to temporarily and safely alter our own cellular machinery, changing the locks on our own doors so the virus has absolutely nothing to hijack in the first place?
Now that takes the chess match to a completely new level.
Something to think about until next time.